So what is variation reduction? It's where we bring small groups of physician peers together. And every word here is important. It has to be small, they have to be physicians, and they have to be peers. Because it has to be a setting where they know and trust each other, and they can create this safe environment. It has to feel confidential. It's not something that a health plan is doing to them. It's not something that's going to get public. And they all have to be there because they're there because they want to change. If they say, well, we're just a new group, we don't really trust each other, okay, you're not ready for this yet. And then pull, not push, is a very important thing because too often we said, I know what the desired improvement is, I know what the evidence is, so here's what you need to do. So this new approach is very different. It's saying, like, I have a feedback tool for data, and what would you like to do? Where do you want to become a better physician? The way we do is we show the variation in care. And we all know that there's huge variation, but we all think we're normal ourselves until you're confronted with the evidence of what that looks like. So our unit of analysis is the episode. So we've licensed software that is what's called episode grouping. So for a single patient around a diagnosis, it looks at all the ancillary tests, imaging, medications, creates an episode. Now here's the key thing. We're going to make it visual and live and drillable. And then we're going to say, what are you curious about? What do you want to look at? In the hope that that exercise will then lead us to a project. So I'm about to do this. I'm about to pull up our database and then say, let's pick a high volume area, high cost, where we have ability to impact. But actually more important than those, where are we curious? Because I'm just saying, this is your tool. What do you want to do? So the goal is to pick one clinical area and then say, what are the differences? What's the variation? And then, really importantly, without judgment, we're just going to say, what are we curious about? And the goal is to be looking for a quote-unquote project. What's something that we can say, yes, that's a standard that we all agree on, and how are we different from that? Let's turn that into an ongoing improvement project. Now, I have a choice here. I'm going to look into one data set that we call de-identified, and it will have all the physicians by number. But because I trust all of you, and because it doesn't work so well with numbers, and the way this really works is when you see your own name up there, I'm going to do it with names, but I'm also asking, taking a bit of a risk and asking that we will not talk about the names we see here to your friends, especially if anyone are in California, because it only works if you really see the names. So honor me in this, and we'll go there. And it takes a little bit for this to load and to look at the data, and you say, well, gee, that's kind of inefficient, and if you have physicians' time, you don't really want to take their time by having this. On the other hand, it's more respectful to say, I didn't know what you wanted to look at, so I brought along with me all the data. So the first thing is we're going to pick what specialty we're going to be, and I'm just going to walk you through one, but then I'm going to turn it over to you guys and say, where do you want to look? So let's look at the episode counts in ENT here. So this is across our entire system, so ENT, we can drill into that. And normally I'd say, where do you want to go? What do you want to look at? So here's different groupings of clinical diagnoses, and otitis media is the most common one, then hearing disorders. I'm going to look at chronic sinusitis. We had almost 2,000 episodes in a year there, so pretty common. And here's chronic sinusitis without surgery is the more common one, so let's look at that. And it shows there's different severity levels. So that's one of the things that physicians always ask for. Does it take account for that my patients are sicker? And that is built into this grouper methodology. Now for sinusitis, I don't think that comorbidities make all that much difference, so I'm just going to skip over that, which means we'll be combining all these together. And I'm going to go straight to region. So I told you Sutter has about 5,000 physicians. We're spread into 5 different regions. Here's their volume of episodes, but it's really not the volume that's interesting. Now let's start looking at the average cost. So I'm going to switch the y-axis to the average cost here. And we'll see that some regions can do this for around $600 per episode and others around $300. So a 2x variation there. But nobody really identifies with a region, so let's go into a medical group. Coming a little closer to home here. And so the medical groups, they also range from about 600 down to about 300. So now if you see your own medical group as one of these high ones, you're kind of wondering, gee, well, what are we doing different than the others? But it really gets interesting when we turn to the provider names. So I usually pause at this point and said, are we ready to see our own names up here? Because this really works with the physicians in the room whose data is up on the wall. So do you guys want to see physician names? Yeah? But some people say, well, you should do this anonymously. And I say, it doesn't work that way. It only works if you care enough to sort of see where you stand. And so the next slide will be the same data, but with individual physicians. And so you have to do a lot to make it safe, that people are ready for that first. So this is all across Sutter. Now, one problem is the first one had 11 cases, 19 cases. So then I say, well, what's a reasonable cutoff for a minimum? Statisticians like 30. You don't always have 30 cases of exactly the same thing. So I'm just going to pick 20, but normally we pick something in the room. But what does the group think is reasonable? So here we're looking at all doctors who had 20 or more cases of 20 episodes of chronic sinusitis. So it looks like Dr. is the highest one at $800, and the lowest one there is at about $250 or something like that. So at this point, it's really obvious what the data says. It says that is a good doctor on the right and Dr. is a bad doctor on the left. It's obvious. We can all read the graph. We can read the data. And insurance plans actually don't go any further than this, because that's as far as they take this data. And they say, let's reward the guys on the right and build a narrow network, excluding the ones on the left, and we've solved the cost problem. And they really think that way, so not helpful. The question, and so let's say that Dr. the one on the far left, is in the room right now. And we say, so Dr. how do you feel? Like, I'm fine. And you don't look like you're fine, and you're probably not feeling fine. So it says, but I bet you're curious what you're doing different, and we're all kind of curious what you're doing different. Are you curious? Well, yes. Okay, let's go there. So now we start digging into what makes us different. Because we thought we were all the same. And now this was from 200 to 800, about a fourfold difference in the physicians. So now they start looking closer and go, well, what makes us different? And so there's that light green on the top that some of them have, others not. The blue area is a big driver. That's E&M coding. The area on the bottom, the light green, is a lot of changes. That's pharmacy. So here's the third guy. He's looks like high in pharmacy. So we can pick any of these. So I say, what do you want to look at? So let's look at pharmacy. Pharmacy is a good one to pick because it's not physician income, it's not group income, it's a little bit neutral. And so no one feels all that wedded to what drugs they use. But wow, big difference here in pharmacy use. So what's driving it? Respiratory agents. Let's click on that. And at this point, people are on the edge of their seat, they're curious, and they say, okay, well, so what is it? So it turns out to be it's intranasal steroids and intranasal products here. So let's look at the steroids. But again, I'd say to the group, what do you want to look at? What are you curious about? And here we all think we practice roughly the same amount of medicine, but turns out not. Some people use a whole lot of this brown one, mometasone. I looked it up, that's Nasonex, and other people hardly at all. And so at this point, I feel a project brewing here, but I'm not going to say anything. I'm going to just be quiet and say, what do the physicians think? And how could we save money in this area? And then I just say nothing and kind of wait for someone to say, well, if they're all steroids, they all work pretty much the same, maybe we should use less Nasonex and more of some of the other ones. And I'm like, well, what does the rest of the group think of that? So you don't have to come with evidence-based. I don't think there is any evidence-based, which of these works any better than the others. So it's more, what does the group think? What would be reasonable as a way to save some money here? And it's not huge dollars. It's what's the average, $40 or $50 for some of them, up to $160. So it's $100 per sinusitis case. But, how do you save $1 million? It's a $110,000 little project. So you got to start somewhere with little things. And the beauty of me being a family physician is that I'm saying, okay, here's an expert saying, in my training I was taught to do this. I don't know what the right thing is. How about you guys on the right? Weren't you taught the same thing? Why don't you do it? Like, well, you don't really need it on every case. And so a conversation starts. And that's the beautiful thing that happens is clinicians are talking about medicine. Their eyes light up. It's like they're in residency all over again, debating what's the right way to treat something. They're not fighting the data, right? Because the data is really obvious. They know from each other, yes, I do a lot of scopes or I don't. And so they're talking about what's the right way to do medicine.